Welcome to the CAMS, CAIPA, and New York City Department of Health and Mental Hygiene tobacco treatment program. We're very delighted to have Dr. Achala Talati back. She's a good friend of CAMS now. She's been doing many programs for us. Dr. Talati is the Director of Tobacco Policy and Programs Unit at New York City Department of Health. She's a board-certified preventive medicine physician and an internist who has led clinical initiatives focused on provider educations and equitable access to care, including development of local tobacco prevention and treatment guidelines and clinical tools. As I said before, she has worked with us, CAMS, many times to help our provider. She had completed her public health preventive medicine residency at Department of Health and Mental Hygiene, her internal medicine residency at Albany Medical Center, and Master of Public Health in Epidemiology and Biostatistics from CUNY School of Public Health and Health Policy. She had presented before, and she actually, personally, I have learned so much on how to approach patients and counseling patients on tobacco cessations. She had provided different pharmacological therapy that's very useful. She provided resources that we all can get, such as a prescribing chart and bilingual pocket guides that really helped me in counseling my patients. And then, from her, we learned that, the rate of Asians smoking is still male, it's still not going down. It's gone down in other ethnic group, but it's not going down in Asians. It's still around 20%. And then, Asians using nicotine replacement therapy is low compared to other groups. It's only like 8.6%. So she has provided a lot of information. I can't wait to hear the program again. Please welcome Dr. Talati.
Thank you so much, Dr. Chen. That was such a kind introduction, so really appreciate that. I feel like you gave highlights of like the first half of the presentation already. So hopefully everyone, finds this useful and, can integrate this into your work easily. But let me just pull up my slides. Great, can you all see that?
Yes.
Okay, perfect. So thank you again for having me. And I especially wanted to thank both CAIPA and CAMS for helping to organize this webinar. And we also did partner with CAIPA on a newsletter article last year, which was a great summary. So highlighting that here too. But this is kind of an overview of what we'll be covering today. So we're going to start by looking at local data, including some of the things that Dr. Chin mentioned to better understand, what this looks like in New York City. Then we'll discuss the standard approach to tobacco treatment and how we can modify that to better support patients. And then we'll review how to actually put that into practice using an ask, assist, and follow-up framework for tobacco treatment, as well as some tools and resources that we have to help you. And all the patient-facing materials and resources that we have are available in both traditional and simplified Chinese. And then finally, there's a couple sample cases if we have time, so you can get a better sense of how this works practically. And I'll focus mainly on smoking today, since that's likely what you'll see most often with your patients. But a lot of the resources I'll share can be helpful for people who vape as well. So I'm happy to go into more detail about vaping or vaping treatment at the end if people have questions. So I wanted to start by looking at tobacco use in New York City using some data from our community health survey. But before we look at some of the local data, I just like to put something like this up so we can talk a little bit just about why people smoke or vape. And so this is a simplified version of the social ecological model, which considers the influence between different levels that you can see here. So individual, interpersonal, community, as well as policy sort of levels on people's behavior. And you can see examples of some of those factors that fall into those levels as well. And we also always note that structural racism and other types of injustice related to people's identities, including gender, nativity, sexual orientation, and socioeconomic factors affect all these levels too. So that may mean that some people are more exposed to harmful factors that encourage smoking, and that includes industry marketing or access to retailers, but also things like stress, and fewer protective factors like access to healthy coping resources, treatment support, or behavioral health care. Also, people have experiences living in another country that can also contribute to an even more nuanced group of influences on their behavior, including, the marketing and the norms and the policies in those countries. And one example is we know the tobacco industry has specifically targeted Asian immigrants and even referred to them as a gold mine, including through community cultural events, youth-oriented promotions, and corporate sponsorship. And they also use strategies like replicating ads and approaches that they were using in Asian countries to promote brand recognition here. So how is this kind of all played out here locally in New York City? So because of advances in science, as well as policy and outreach efforts at the federal, state, and local levels over the past couple decades, including several that you can see on this slide, there has been about a 50% decrease in smoking from 22% in 2002 to 10.9% in 2020. However, these benefits have not been experienced equally by everyone. So let's look a little bit more closely at some of the data. So many disparities that were apparent 20 years ago are still evident today in New York City. Men are still more likely to smoke than women. The smoking rate is about 70% higher among men. People with less than a college education are more than twice as likely to smoke as college graduates. And people who live in high poverty households are more likely to smoke than those in low poverty households. It's also really important to consider intersecting identities, including, sort of the different social and political histories of people from different communities and countries that they bring with them. So if we actually look at smoking prevalence in New York City just by race and ethnicity, the rates are now essentially the same across all groups. But if we look at multiple factors together, like race and ethnicity and gender and nativity, it can reveal inequities. So if we look at how smoking rates among men vary by race, ethnicity, and nativity, we find that the smoking rate is significantly higher among Asian men who were born outside of the US than US-born Asian men. And this difference is actually even more pronounced among Chinese men. Those who were born in the US, the smoking prevalence is only 5%, and those who were born in China, the smoking prevalence is 27%. And you can see that the pattern is actually different among Black and Latino men. There, the smoking rate is actually higher among US-born Black and Latino men compared to those who were born in other countries. And for women, we also see similar patterns for US-born Black and Latino women compared to those who were born in other countries. And the pattern for Asian women is also similar, with higher rates among US-born Asian women than those who were born in other countries. And some of these differences may be due to smoking prevalence in native countries compared to the US, which may be related to differences in tobacco regulations and industry practices in those countries, among other factors. So I think that's maybe part of what we're seeing for Asian men here. And the differences could also be driven by structural racism and tobacco industry campaigns in this country. For example, for Black and Latino New Yorkers who were born in the US, who the industry is specifically targeted in some campaigns. So understanding these differences can help us to better address tobacco-related inequities, including hopefully with treatment. And so this slide, which I think Dr. Chen also referenced earlier, shows that if someone reported using nicotine replacement therapy in the last 12 months by race and ethnicity among adults who smoke in New York City. And our most recent data on this is from 2016, but use has typically not changed much over time. And so the NRT types referenced here include nicotine patch, gum, lozenge, nasal spray, or inhaler. And Asian New Yorkers who smoke, as you can see, are significantly less likely to have used NRT than those identifying with any other race or ethnicity category. And low NRT use among this group may be contributing to the lack of declines in smoking rates among Asian New Yorkers. And so that's one of the reasons I'm so glad that we're talking about this today, so that hopefully you feel more equipped to talk about tobacco treatment with your patients. And so now that we've looked at some of the data, I just wanted to reiterate why this is such an important health issue. So smoking remains a leading cause of death in New York City. An estimated 12,000 New Yorkers die from a smoking-related illness every year. And there are over 700,000 adults who smoke in New York City, and about 70,000 of them are Chinese. And up to half of people who smoke long-term will die from a smoking-related illness. And the reason this is true is just because smoking impacts nearly every organ in the body. And you're likely very familiar with all the risks of smoking, but I just wanted to include this as a reminder. And I think patients often think first about lung cancer or COPD, but smoking can cause over 10 types of cancer and many other chronic diseases, including stroke, diabetes, and even autoimmune disease like rheumatoid arthritis. We're also still finding new associations. So every disease that you see listed in red, like liver cancer, colon cancer, diabetes, those were new additions in the 2014 Surgeon General's report. Also, sort of more recently relevant is COVID-19. So smoking also does increase the risk of severe illness with COVID-19. Secondhand smoke also causes disease and about 40,000 deaths each year in the US. There's no safe level of exposure to secondhand smoke. And you can also see some specific risks for children. And for adults, secondhand smoke can also cause stroke, heart disease, lung cancer, and other health problems. So as we've reviewed, although we've made progress, there are still many New Yorkers who smoke and need support. So let's kind of look at our standard approach and how we can change it to better support patients. So this is something you're also probably familiar with, the stages of change, since they're often used as a framework, not only for tobacco treatment, but really any behavior change. So it includes 5 stages from pre-contemplation. So for smoking, that would be someone who's not interested in quitting and has no plans to change. To contemplation, someone who may be considering quitting but is ambivalent. To preparation, someone who's starting to plan to quit and has started taking some steps in that direction. To action, someone who's recently quit or is actively trying to quit. And maintenance, so someone who successfully quit in the past and is trying to maintain that change, noting that relapse is always possible. So what's our standard approach? It's usually to offer motivational interviewing and some practical counseling to everyone who smokes, regardless of what stage they're in. And then also to offer medication-assisted treatment, whether that's with nicotine replacement therapy or NRT, varenicline or Chantix, or bupropion SR or Zyban, but really mainly only to people in these bottom 3 stages, preparation, action, and maintenance, and maybe to some people in contemplation. But that means everyone in pre-contemplation is only being offered motivational interviewing, if that. For a lot of people, it may just mean someone asks them if they're interested in quitting, they say no, and that's kind of the end of the conversation. So how can we offer more support to patients, in this group and increase chances of future success quitting? And the short answer is really just by extending that offer of medication-assisted treatment to everyone who smokes, along with motivational interviewing and practical counseling. So how can we do this safely? And the short answer is with NRT. So in 2013, the FDA felt there was enough data to approve NRT label changes to remove warnings about using 2 forms of nicotine at the same time. And that includes NRT and smoking, because there really were no safety concerns. And then also to remove directions that instructed people to stop using NRT after a specific number of weeks. Again, because there were no safety concerns with people using it for longer if they needed to. And so, although we usually only think about NRT as a tool for people who are ready to quit, it's already also commonly used while smoking in at least 3 ways. So one is sort of prior to a quit attempt, which is at least as effective as starting NRT on a quit date and may increase the likelihood of a successful quit attempt. The second is for gradual cessation via reduction, so kind of cutting down over time, which can improve the likelihood of quitting successfully, even for those who aren't intending to quit. And the last is for craving relief or sort of temporary abstinence, like to help people manage withdrawal symptoms when they're in places where smoking is prohibited. And this is something that we've all seen, in hospitals or other inpatient settings. But there's also evidence that simply trying NRT or sort of sampling it can meaningfully impact motivation and self-efficacy around cessation, even for those with low or no motivation to quit. And this impact may be even greater for people with lower income and education. And so what are the takeaways from all of that information? So first, that NRT is safe to use while smoking, potentially even for long durations of time. Second, that medication-assisted treatment with NRT can be effective, even for people who aren't intending to quit. It also promotes ongoing engagement with you or with other providers about their tobacco use, even if they have no interest in quitting. And then finally, NRT can be an important tool to support patients reaching other goals. So like following a workplace or residential smoke-free policy, that can mean giving someone the chance to feel confident about applying for a job or housing where they know they won't be able to smoke. Protecting those around them at home, participating in activities in public spaces, saving money, and gaining confidence with managing medications, since NRT, especially short-acting NRT, is a medication patients can kind of self-titrate to some extent. So coming back to this new approach, it's definitely possible, especially using NRT for patients who are in pre-contemplation or contemplation. So how does this all actually work in practice? You know, how can you incorporate this into your existing work with patients? So I'm going to share a new toolkit kind of based around this approach, including some resources for you, your staff, and for patients, showing how you can incorporate them into your day-to-day work and using this framework of ask, assist, and follow up. So as an overview, what does this approach look like? What are the key steps? So first, ask every patient about their smoking and assess smoking patterns as well as readiness to change. The next is assist. So assist by counseling and discussing the importance of treatment with all patients who smoke, and then based on their smoking pattern and their goals, prescribe medication options and provide resources. And then finally, follow up. So ideally within 1 to 2 weeks to ask about initial use, any issues, symptoms, etc. And then again in 6 weeks to assess progress and need for any changes to the treatment regimen. So let's go into all of these in more detail. So starting with ask. So ask about smoking at every visit and assess smoking pattern. So these are questions that may already be built into your EMR, but these are key questions that can later help you guide which medications you'll prescribe. So first is, how many cigarettes do you smoke each day? Up to 10, more than 10, or is this someone who doesn't smoke every day? And then how soon after waking do you smoke your first cigarette? Within 30 minutes, more than 30 minutes after waking, or again, is this someone who doesn't smoke every day? And then avoid asking if someone is a smoker, since some people may not identify that way, especially if they don't smoke every day. And then aside from assessing smoking pattern, like we talked about, it's also necessary to kind of assess readiness or motivation to change. And that's definitely something you can do during a discussion using motivational interviewing techniques like open-ended questions and reflective listening. But we also have a tool that you can use. It's a quiz that patients can take, whether at home or in the office, to understand the relationship to tobacco. And based on their answers, the quiz will tell them how ready they are to talk about tobacco, essentially their stage of change, which can be not ready or interested, thinking about it, preparing for it, taking action, or maintaining change. And then for whichever stage they're in, it gives them some feedback and advice, including advising them to consider treatment to help them reach their goals. There's also a separate key for you or for other staff, which provides guidance on how to help someone in each stage. So it emphasizes discussing tobacco use and treatment with all patients and provides advice on some of the best ways to do so based on which stage they're in, including examples of things that you can say to them. So that includes some key actions that are always relevant, regardless of stage, like motivational interviewing approaches to understand and clarify goals, providing counseling, including some practical support and advice, and then discussing tobacco treatment medications, whether that's to stay comfortable in places or situations where they're hoping to avoid smoking, or if it's for someone who's already on treatment, following up on potential issues with medications, such as needing a different dose or needing help with access, which we'll come back to later. I did want to note that tobacco treatment medications are not recommended as first line for pregnant people, though exceptions can be made on an individual basis. But I'll talk more about kind of all three of these items, especially medications, in more detail. And please feel free to put any questions in the chat as we keep going too. So I won't spend a lot of time on motivational interviewing, since I think that's something we could easily spend all of our time on, but I wanted to just share some key concepts here, which are probably familiar, including expressing empathy, listening actively and affirming how your patient is feeling, developing discrepancy between goals and actions. So scaling questions can be really helpful here, to gauge what's important or how confident people feel about making a change. For example, on a scale of 1 to 10, how important is it for you to change your tobacco use? And that's a great one to kind of prompt a conversation. So even if someone says they're a 4, it's an opportunity to discuss, why they're not a 1 or a 2. And then rolling with resistance and avoiding argumentation, really trying to keep a neutral position and help someone understand where they are. And then supporting self-efficacy. So treatment can be a really great tool here to help build self-efficacy around current goals, even if someone is not ready to cut back or quit completely. It can also help to open conversations by just asking patients to tell you about their smoking and finding out if there are specific times when they want to avoid or limit smoking. For example, it sounds like you're not interested in quitting smoking, but you do try to avoid smoking at home and around your family. Can I share some options that might help you avoid smoking at those times? There's also some general guidance and counseling that you can provide to all patients who smoke. So first, review any lessons learned from previous attempts to stop or reduce use. That can include issues with medications that they had in the past or persistent cravings, and that may help you decide what medication options make sense for them right now, as well as triggers or stressors. So if someone is not ready to quit, focus on situations where they may be trying to stay smoke-free, like at work or at home, and learn about potential triggers there. And then discuss potential strategies for their triggers. So is that their morning coffee or a lunch break or a specific situation at work? And offer ways they could change routines, replace behaviors, use distraction tools, or avoid certain spaces to help them limit smoking when they want to. And that depends on what their routines are. But for example, it could include taking a different route to work, taking a break at a different time than with other colleagues who smoke, switching what hand you hold your coffee cup in, or switching to a different drink like tea. And there's some other suggestions and ideas in the coaching guide that we have, which you can see here. And if people are ready to quit, you can also recommend doing some things like removing physical triggers from the home, like ashtrays and lighters. And you can also recommend setting a quit date if someone is open to that approach. So now moving on to medications, which medications are we talking about? So first is NRT. There are 5 types: the patch, which is long acting throughout the whole day. And then there are 4 forms of short acting NRT: gum, lozenges, nasal spray, and inhaler. Then there's 2 oral medications, varenicline or Chantix, and bupropion SR, which is also known as Zyban or Wellbutrin. And there are more details about all of these medications in our prescribing chart, which you can see here. So it includes dosing information, precautions, contraindications, and potential adverse effects. But we're also going to talk about all of these in a little more detail today as well. So how do you decide what to prescribe to patients? So it's based on 2 things, their smoking pattern and the patient's goals. So for people who aren't ready to quit, starting with short-acting NRT is a great option in most situations, especially if someone might be smoking still occasionally throughout the day. This will give them more flexibility since they can use it whenever they need to, and they can kind of self-adjust or self-titrate how much they're taking. Combination NRT with the patch and a form of short-acting NRT can also be considered in some situations, especially if someone is trying to avoid smoking for longer periods of time, like a full day work shift or a day indoors with family members. And then if people are ready to quit, combination NRT or varenicline are the 2 most effective options. So one of those 2 should really be first line for you if someone's interested in quitting. You can also consider bupropion SR with or without short-acting NRT. That might be a good option for someone if you're also trying to treat depression. So let's talk about these medications in a little bit more detail, starting with NRT. So these are the 5 types, again, of NRT that are available. The patch, which is the only long-acting form, so this works throughout the whole day. And then the 4 short-acting forms, the gum and lozenges, which are available either by prescription or over the counter, and the inhaler and nasal spray, which are only available with a prescription. All of these forms of NRT are generally safe to use for tobacco treatment because the primary ingredient is nicotine, which people are already being exposed to while smoking. But in this form, they're able to get the nicotine to counteract withdrawal symptoms without the other toxic chemicals generated via combustion. And regardless of the type, the patch and one of the short-acting forms can be used together, and this actually does make the NRT more effective. So clients can self-administer short-acting NRT and adjust as they need to, like using another lozenge or another piece of gum when they have a craving or when they know they would normally smoke. And you can kind of think about this like asthma treatment, where you have a controller medication that's longer acting, and then you also have a rescue medication that you can use for immediate symptoms, or like some insulin dosing if you're using kind of basal and preprandial insulin. And so for your clients and for you, we also now have this pocket guide to all 7 forms of medication. And so for each one, it has pros and cons, as well as instructions for use. And this can be really helpful because NRT is not always intuitive. So for example, the gum especially is not always intuitive, that you can't just chew it like you would chew normal chewing gum, and that you have to actually kind of park it between your gum and your cheek and let it sort of slowly absorb. And, you know, for the lozenges, explaining that you can't chew them and you need to let them dissolve slowly. All of those kind of tips and instructions are in this pocket guide. And it also has pros and cons. If people kind of aren't sure what they want to try, they can kind of learn about the different options as well. And then at the end, it also has answers to some common questions about NRT, like you can see here, including about using NRT while smoking, explaining that that's safe to do, and about using multiple types of NRT together, explaining that using a patch and a short-acting form together actually makes NRT more effective. So it has, you know, all of that information in one little booklet. And for you, I just wanted to review the dosing in a little bit more detail, just so you're familiar with it. And the 2 questions about smoking pattern that I mentioned earlier will guide dosing for the patch, gum, and lozenge. So the patch dosing is based on cigarettes per day. As you can see here, either 1 to 10 or more than 10. And then the gum and lozenge dosing is the same based on how early someone has their first cigarette after waking. The inhaler and nasal spray don't have different doses. So there's just a single dose, and you use it as a short-acting medication, which could either be scheduled or just as needed, or both. So for example, someone is trying to avoid smoking while working at home with their kids, you could say, you know, start with using the inhaler or a lozenge every 2 hours. But if you have additional cravings, you can also use it additional times as needed. And so that's also why it's important to kind of counsel patients on how to interpret their symptoms to understand dosing, since they can kind of self-adjust to some extent with short-acting NRT. So if someone is still having cravings or is feeling irritable, then they may need more NRT, and they can take another lozenge or another piece of gum, or they may need the dose adjusted up. If someone's feeling nauseous, has an upset stomach, and feels their heart racing, kind of like how they may have felt when they smoked their first cigarette, they probably have a little bit too much nicotine, and they could hold a few doses. And this is also something that's included in the pocket guide. So you can kind of go through it with them if you have that in front of you. And then what about oral medication? So varenicline or Chantix, as I mentioned, is a first-line medication for treating tobacco use, given its efficacy. It works as a partial antagonist and agonist at the nicotine acetylcholine receptor. So it blocks some of the effects of nicotine from smoking while also partially stimulating the nicotine receptors. Bupropion is not first line, as I mentioned, but it is, of course, also an antidepressant. And during some of the initial trials for that indication, it was found that it also helped with smoking cessation. So it was studied for that and found to be effective. So it may be a good option if someone also has mood symptoms that you're trying to treat. I won't discuss it in more detail today because it's not first line, but I will note that it does have a lot of interactions with other medications, as well as several contraindications and precautions. So it's important to kind of look through those if you're considering it. One thing that I did want to emphasize is, some people might remember that there were black box warnings for serious mental health adverse reactions related to depression and suicidal thoughts. Those were actually removed in 2016. And that was based on an FDA review of a large clinical trial called the EAGLE study, and which is very unusual. Black box warnings are not removed very often, but the evidence was that strong that they felt they could remove it. So although these side effects are still possible, the FDA found that these reactions were similar across groups, including with placebo, and they generally didn't result in serious consequences or hospitalization. So that's why they removed the warnings. I did want to discuss varenicline in a little bit more detail since that is a good frontline option. So you can see that there are a few different options in terms of regimens, including a fixed quit date on day 8, a flexible quit date sometime between day 8 and 35, and even gradual reduction where you just try to reduce smoking by half every 4 weeks with the goal of completely stopping by week 12. So there are definitely options if someone's interested in Chantix, even if they're not ready to quit right away. And you can also see the specific dosing on the prescribing chart, but essentially you start with 0.5 milligram daily and you titrate to 1 milligram POBID over a week. And you use varenicline for at least 12 weeks, but often using it for longer is helpful. Studies have found that use for up to 1 year can help prevent relapse. And you can also see precautions and side effects here, which are generally very limited. The most common ones are nausea, which may dissipate after titrating up the medication or by taking it with food, as well as insomnia or vivid dreams. Unfortunately, there's not an easy fix for insomnia or vivid dreams. So if that's causing substantial discomfort, then I would recommend switching to NRT. You can monitor for neuropsychiatric symptoms, but as mentioned, studies have found these were limited, including compared to other options in placebo. Cardiovascular events, but these are very rare and it's very low risk, similar or lower to NRT, and some others that you see here, which were even less frequent. Another thing that I wanted to mention is that the chemicals in tobacco smoke induce P450 enzymes. So when someone cuts down on smoking with or without medications, other medications may be metabolized less slowly and their dosing may need to be decreased. Some of the most common ones are listed here, including caffeine. So that's an important one to relay to patients, that caffeine metabolism decreases by up to 70% when someone stops smoking. So if someone's cutting down on smoking, they should also consider cutting down on caffeine, especially to avoid insomnia or restlessness. And nicotine doesn't induce the P450 system. It's actually the tobacco smoke itself that does. So all of this still holds true, even if someone is using NRT. And then finally, regardless of the goals or initial dosing, follow-up will definitely be critical. Like I mentioned, NRT use is often not intuitive, so some guidance and coaching may be needed. Dosing may need to be adjusted or titrated, especially if someone's goals change. And then monitoring for any adverse effects or lack of effectiveness is also important to ensure that people have the best options, since we're lucky that there are a few different options. So within a couple weeks of treatment, someone should follow up just to ask about any issues filling the prescription or initially starting the medication. And then within 6 weeks, really follow up to assess progress in terms of medication use and effectiveness at reaching their goals. It's a time you can modify the prescription as needed, adjust any other medications, provide support, and schedule additional follow-up. So now that we've discussed the medications, how can patients access them and what's covered by insurance? So we have a resource for patients that covers this information, including ways to access medications without insurance, but I just wanted to review that a little bit. So to go into a little more detail, New York State Medicaid actually covers all 7 tobacco treatment medications with no prior authorization or course limits. And it does support prescribing 2 medications simultaneously. In order to ensure that prescriptions aren't denied, they do need to be written for 30 days with refills versus 90 days, and ensure that the daily dose doesn't exceed the maximum. I also wanted to note that there were changes that removed the limit on the number of counseling sessions that are covered, so there's no maximum. Also, additional providers, including social workers, RNs, LPNs, and clinical psychologists can bill for counseling as well if they're in your practice. And Medicare is different. It actually only covers medications that are not available over the counter. So that would be the nicotine nasal spray and inhaler, along with varenicline and bupropion. Private insurance, including employer-based plans, there the coverage is more variable, but the guide that I just showed you, it actually does have a section with tips on how to figure out, what someone's plan covers. Another thing that I did want to mention was just prescription discount cards. So people can utilize the Big Apple RX or pharmacy discount cards, but they will still need prescriptions from you in order to use those. And for those who do not have any insurance, there are also some other local resources. I did want to flag that they're geared to people who are ready to quit for the most part, but you can see them here. And so to just talk about some of those, the first is Quit Lines, which are a great resource. So the New York State Quit Line provides at least a 2-week supply of combination NRT with patches and lozenges, along with counseling to almost all adults who smoke or vape. And actually currently 4 weeks is being offered, and New Yorkers can access this directly online or via phone. You can also help someone fill out the form to enroll online, and they will receive the medication in the mail along with a follow-up coaching call. The counseling is always provided over the phone. And after enrollment, like I said, a quick coach will make at least one follow-up call, but people can call the Quit Line themselves anytime they want if they have questions or need advice. The Quit Line also has enhanced services, so extra coaching and medication support for priority populations. And that includes people who are pregnant, people who are experiencing psychological distress, who have disabilities, report alcohol dependence, or use cannabis. And then also for people whose preferred language is Chinese or Korean or Vietnamese, there is the Asian Smokers Quit Line, and there people can access counseling and coaching support directly in their preferred language. And the Asian Smokers Quit Line also works with the New York State Quit Line to ensure that people who enroll and are from New York are able to get the same free medication that they would get if they contacted the New York Quit Line. And again, people can enroll online here as well or over the phone. We also have several local programs throughout the city, and you can find these listings on the New York City Health Map, and people can filter by different criteria, including availability of free or low-cost medication. And all of these listings are also in our guide to smoking cessation programs, which is kind of like a directory of these programs by borough. And it includes some citywide resources as well. Another resource that we have is a 15-minute training video, which recaps some of the key concepts that we covered today, including background on smoking and nicotine dependence, the 5 types of NRT, and how NRT can be helpful even if someone's not interested in quitting. It was designed to really be accessible for many audiences, including non-clinical staff, clinical staff, or even patients. We have had some partners who've used it in group settings, and we won't watch it today, but please feel free to share this with others in your program as sort of a quick primer if that's of interest. And then all the tools and resources that we talked about today are accessible via our webpage for clinicians. And the new NRT toolkit, of which we discussed many of the resources, is highlighted at the top of that page. The page also has some other resources like the medication prescribing chart that we discussed, along with a billing guide for counseling. And for patients, you can direct them to our NYC Quits page. That includes information about local programs, as well as some additional materials you can see here. For example, Quit to Save, which focuses on financial benefits of quitting smoking. We also have our Coping with Nicotine Withdrawal page, which has all of the new toolkit items that we talked about today as well. And again, all of these are available in traditional and simplified Chinese and can be ordered via 311. So I know we covered a lot of information, so I just wanted to end with some key takeaways. So more than half of adults who smoke try to quit each year. Abstinence rates can increase up to 28% with optimal treatment, including medication and counseling. And even brief counseling, 3 to 10 minutes, has a measurable impact on future success. And then, sort of our recommendations for you are ask all patients about their smoking history and offer tobacco treatment to all patients who smoke, based on their goals. And I have a couple sample cases, but I also wanted to, I have a couple sample cases, but I also wanted to, ask if people had questions before we go to those.
So there are actually 2 questions in the chat.
Oh, great. Do you mind reading them? I'm sorry. I'm having
Sure.
like an issue with my mouse, so hopefully I can
No
fix it in the
problem.
next minute.
No problem. So, so there's 2 questions. One is, why do Asian New Yorkers have such a low NRT rate? And then there's also a question about their use of Chantix, if the usage rates are also low for Asian New Yorkers.
So I guess I'll start with that second one first. That's a great question. Unfortunately, I don't know the answer to it. So that data was from our community health survey, and we haven't asked about Chantix before in that survey, but I think we are hoping to ask more questions about treatment use, including NRT, as well as other types of treatment in future surveys. So maybe that's a question we'll be able to answer in a year or two. In terms of why, I think it's a great question. It's also a question that we actually share several partners, including CAMS and CAIPA, and ask them, why they think this use is lower. And I'm guessing it can be, there may be several different reasons. Maybe people are less familiar with medications. Maybe people are hesitant to use medications to quit smoking, like they feel like it's something they should be able to do with just, kind of willpower or kind of mental strength. So I think there probably are a few different reasons. You might have some good ideas or guesses as well. Any other questions, or would it be helpful to do a sample case to kind of review some of the information, whatever people prefer?
Yeah, let's do some cases. Those are interesting cases, I remember.
Okay, great. Let me just pull slides back up. Okay, great. So this is the first sample case. So Carl Lee, he has a history of schizophrenia, history of seizures secondary to head trauma. He's 42 years old. He's been smoking since age 12 and has smoked up to 2 packs a day. Currently smokes about 1 pack a day and usually smokes his first cigarette about 30 minutes after waking up, right before breakfast. He's never had a period of tobacco abstinence in the past. His schizophrenia has been stable for several years. He currently lives in a smoke-free building, but he's having trouble avoiding smoking at home. His landlord has already noted a couple complaints which violate his lease, so he's worried about how he'll stay smoke-free at home since he doesn't feel confident about being able to quit. His medications, he currently takes Seroquel for his schizophrenia. So this is the first question for you. It's multiple choice, so feel free to put some answers in the chat. What's the preferred treatment for Carl Lee? A, no prescription. Quitting smoking may affect his mental health and he's not ready to quit smoking. B, 2 milligram nicotine lozenges. C, a nicotine inhaler. D, a 21 milligram nicotine patch and nicotine inhaler. Or E, bupropion SR. So what do people think? Feel free to put answers in the chat. So I see Dr. Chen said nicotine patch and inhaler. Any other guesses? So that was correct, but it was a little bit of a trick question because I think both of these could actually potentially be good options. We probably need a little bit more information about how long exactly he wants to stay smoke-free for at home. If it's for extended periods, like most of the day, then combination therapy with the patch and inhaler could make sense. But regardless, treating his tobacco use in general is important. So A is incorrect. Nicotine lozenges could also be a good option, but based on his history, 4 milligrams would be the best starting dose because he smokes his first cigarette within 30 minutes of waking up. And bupropion SR is not the best option given his goals, but also because his seizure disorder is a contraindication for use. So second case, this is Naomi Walker. She's 38, has a history of hypertension, hyperlipidemia, started smoking in college and currently smokes half a pack per day, about 10 cigarettes. She has her first cigarette with her morning coffee about an hour after waking up. And she previously quit smoking during pregnancy. Excuse me. Her brother recently had a heart attack and she's been trying to cut back on smoking unsuccessfully. So she's interested in quitting, but is hesitant about quitting all at once and asks about options. And her current medications are lisinopril and amlodipine for the hypertension, as well as atorvastatin for the hyperlipidemia. So what would be the preferred treatment for her? A, no prescription, wait until she's willing to set a quit date. B, 21 milligram nicotine patch and 4 milligram nicotine gum. C, nicotine nasal spray. D, 14 milligram nicotine patch and 2 milligram nicotine gum. Or E, varenicline. So which one would make sense for her? And I can put this up for a second again in case it's helpful to see. And these are the options. So feel free to put an answer in the chat too, if that's easier. So any guesses on what the best option would be? So I see Dr. Chin said still NRT, maybe Chantix. And I think, yeah, both of those could be good options. So all three of these could be potential options depending on how quickly she wants to start cutting back. If you could start with just short acting NRT, like the nasal spray, potentially with, kind of fixed dosing every couple hours when she's not smoking, and then gradually add the patch to that when she's ready to cut back more significantly. If she's ready to cut back more quickly, you could start with combination NRT. And like I mentioned earlier, varenicline does have a dosing option where you cut back gradually over 12 weeks, reducing smoking by 50% by week 4, another 50% by week 8, and then, continue to reduce completely by week 12. But there's definitely not a need to wait, especially since she is interested in quitting. So A is incorrect. And the other combination NRT answer here is just too high of a dose based on her smoking history. She only smokes half a pack per day and doesn't smoke her first cigarette until more than 30 minutes after waking up. So I will stop there. Happy to answer any other questions. I see, are there any concerns that nicotine will increase blood pressure, heart rate, or affect an arrhythmia? So, the main ingredient in NRT is nicotine, but if someone is smoking, then they're already being exposed to a certain amount of nicotine. So as long as you're dosing it appropriately and kind of giving them approximately how much nicotine they're kind of giving up by cutting back on smoking or stopping smoking, then you're not really exposing them to anything new. So it shouldn't really affect them more than that. You can always titrate up or down, as needed, but it shouldn't affect them more than smoking already does. As long as, their blood pressure, arrhythmia are well controlled, then it shouldn't be a problem. Any other questions or anything else that would be helpful to talk about? Oh, I see a comment too in the chat that someone said a politician smoked a lot, but lived to an old age, and so he doesn't want to quit. And I think that's something we hear a lot, like, well, I know someone smoked and, they didn't have any health issues from it, so it's not really a problem. And I think in that case, you can also focus maybe like, are there times already right now where they try to stop, they try to avoid smoking? Do they try to avoid smoking at home, around their family, and kind of build on that? Because then you can say, well, this is something that can help you, stay comfortable when you're in those situations that you're trying to avoid smoking. And then, hopefully over time, you can kind of build on that. They might get more comfortable with using NRT and, might just start cutting back themselves more over time.
Yeah, we encounter a lot of that when we do workshops in senior center, and these old men come up and say, well, I've been smoking all my life and I'm almost near deathbed now anyway. Why should I quit now? I've been happy all my life. And when we tell them that, yes, you might feel healthy now, but you quit smoking now, one, you will feel better. Two, better breathing and better circulations, you move faster. And then we start talking into well, what about secondhand smoking, third-hand smoking, affecting your family, your grandchildren? So that's how we approach. Yeah, it's very stubborn to get the elderly to quit smoking.
Yeah, that makes complete sense. And I guess if there are any other symptoms that are bothering them or other goals that they have, like, that they like to walk with other people around the neighborhood, or there's something else that you notice, like they've been having an issue with coughing or something like that, then that could be something that you focus on as well. Great. Well, that's everything I have. I'm happy to stay on for a few extra minutes if anyone else has questions, but I know you all are very busy. So, thank you so much for your time, and hopefully some of this will be helpful. We'll send out a follow-up email with the slides and links to a lot of the resources that we mentioned.
Oh, thank you so much, Dr. Talati. The talk is very practical. It's very useful. We learn a lot of useful information. Thank you for doing this talk.
Of course. Thank you so much for inviting me.